Um, Hello, everyone. Today, let's discuss ectopic pregnancy. Our discussion is going to be more of a question where I'm going to answer some few questions in relation to ectopic pregnancy. What is an ectopic pregnancy? Ectopic pregnancy is when a fertilized egg is attached to fallopian tube, ovary, abdominal wall, or in the cervix. Really, this or fertilized eggs is not in the uterine cavity, it's outside and continue to grow outside the uterine cavity. Now, an untreated ectopic pregnancy, it's an emergency. It need to be diagnosed. It need to be treated as soon as possible so that you can reduce the risk or complication to the mother. Approximately 1 to 2% of all pregnancies in the whole world are ectopic pregnancy. What causes an ectopic pregnancy? An inflammation and scarring of the fallopian tube by infection or surgery can cause an ectopic pregnancy. Hormonal factors, genetic abnormalities, and some birth defect can be associated with ectopic pregnancy. Now, smoking increased your risk of ectopic pregnancy by twofold. Women of the age 35 to 44 has 3 times fold risk of ectopic pregnancy compared to younger group. What is the risk for an ectopic pregnancy? Maternal age, as I said, above 35. History of pelvic surgery, that can be due to ectopic pregnancy itself. That can be due to tubal reanastomosis. That can be due to tubal reconstruction. That can be due to even appendix. All are associated or have increased chances of ectopic pregnancy. The recurrency risk of ectopic pregnancy or previous ectopic pregnancy, you have got 10% chance of having ectopic pregnancy. If you have 2 or more ectopic pregnancies, you have 25 to 30% chance of having ectopic pregnancy in your next pregnancy. Therefore, it's very important that if you have a history of previous ectopic or twice, immediately you missed your periods, you go to a gynecologist to confirm that the pregnancy is intrauterine or the pregnancy is out of the uterus. What are the symptoms of ectopic pregnancy? Pain is the commonest. Abdominal pain, pelvic pain, low abdominal pain, shoulder pain, vaginal bleeding, spotting, discharge, dizziness, fainting, and amenorrhea. Those are the commonest symptoms of ectopic pregnancy. The diagnosis of ectopic pregnancy can be done early by transvaginal ultrasound, gynecological ultrasound, around 4.5 weeks, beta ACG as well, pregnancy test, or by laparoscopy. Now, the other question I would like, how can we treat an ectopic pregnancy? We can treat ectopic pregnancy by medication. Medication, if your ectopic pregnancy is found very early, I would say below 6 weeks. There is no free fluid in the peritoneal cavity. There is no presence of any cardiac activity on the ultrasound, and the beta HCG is less than 5,000 international unit per liter. Therefore, in that case, you can be given a medical treatment, and the doctor must be sure to follow you closely and make sure that you don't complicate. Then surgical treatment, it's another option. Now, surgery for ectopic pregnancy can be laparoscopic, and in that case, you do what is salpingostomy. By that, I mean you open the tube and just remove the product of conception, and then you can either close or leave the tube as it is. This is a very conservative procedure for the patient to avoid removing the whole tube. And it's very important that if you do this procedure, the patient has there is no rupture of the tube. In other words, we have picked or diagnosed ectopic pregnancy very early. Laparoscopic salpingectomy is whereby the tube is removed, and this patient automatically cannot be pregnant from that tube because the tube is being cut off and the fimbriae are gone, and the tube cannot function to pick up an egg so that fertilization can happen in that tube. Then expected management as well is possible, but this is also other serious precaution. Whoever trying that should be very, very careful, and be also looking for complication at all time so that he can either change to medical or even to surgical treatment. Ectopic pregnancy and assisted reproductive technique. Approximately 1 to 4% of pregnancies out of assisted reproductive technique, either by induction or ovulation, will end up in ectopic pregnancy. Approximately 4.5% of pregnancies from IVF or embryo transfer will end up in ectopic pregnancy. Therefore, in both induction of ovulation or in IVF or embryo transfer, you have the risk of between 1 and 4% of having ectopic pregnancy. Ectopic pregnancy in previous surgery. Yes, if you had any previous surgery, the accumulative probability of ectopic pregnancy for all method of tubal sterilization is about 7.3 per 100,000. Therefore, a woman who sterilized before the age of 30 by bipolar coagulation has 27 times higher probability of ectopic pregnancy compared to another form of prevention like postpartum salpingectomy. Now, a woman who had used an IUD for more than 24 months with his 2 years have 2.6 times or more likely to have ectopic pregnancy compared to a woman who is not using any form of contraception within that 2 years. 2.6% time higher. Indeed, 4 to 17% of all accidental pregnancies are tubal in those with copper or progesterone-coated IUCD, respectively. Therefore, in short, that if you use an IUD or in any whether copper or medicated with progesterone, we have got 4 to 17% chance. If you are pregnant, it should be an ectopic pregnancy. Then, in other words, putting a loop per se can also increase your chances of having an ectopic pregnancy. Now, the last topic I would ask to discuss is how do we prevent ectopic pregnancy in our patient, because our center do more of laparoscopic tubal reversal. We're getting good result in those patients and we follow them. The golden rule in this patient is that they should avoid attempting sexual activity or to be pregnant within the next 3 months. That can be 3 consecutive menstruation after the procedure. Then they should try to be pregnant from there. However, if you do attempt to be pregnant after tubal reanastomosis, the tube after the procedure tend to swell, and where we have actually combined the tube, the scarring hasn't gone. Therefore, giving a tube rather to heal properly and the scarring is cleared off, then the tube now is not a danger for for pregnancy. In other words, the sperm will be able to pass through where we have connected the tube, and fertilization will happen on the other side, and then a fertilized egg will be able to cross from the from one side of the tube into the ovarian cavity, and implantation will be intrauterine. Thank you.